nurse or a SANE nurse, and also psychiatric nurses. So if that's ever something that you are interested in, like a sexual assault kind of nurse, that would be someone who performed examinations on patients who might have been undergone a sexual trauma or sexual rape or things like that and needed investigation. All right, this is just talking about collaboration. We've talked about this. I'm going to let that go. We all know about pre-hospital services, EMTs, medics, and things like that. We all know people that we collaborate with. I want to get us to talk about this for a second. So if you did choose to work in the ER, you would need to hold some different certifications than you would on a floor. Everyone needs their BLS certification in the ER. Additionally, you would need your ACLS, so your advanced cardiac life support. You'd also need that on a telemetry unit or an ICU. The other thing that you would need that's unique is you would need your PALS, which is your pediatric advanced life support. If you guys remember at hospital special care, I showed you like the Braslow tape and the pediatric algorithms that all came from the PALS class. ENPC is emergency nurse pediatric course. Some hospitals may offer you one versus the other. Traditionally, it seems like now it's more PALS. There's also what's called TNCC, so that's a trauma nursing core course that you would have to take, and then having to be telemetry certified and AV certified. If you are specifically interested in the emergency nurse, you can be part, I don't know if anyone visited the table, but there's the Emergency Nurse Association. It would definitely be something to join, and this is the link to their site if you're interested in checking that out before you graduate. All right, so in nurse, and you guys know this, but the one piece I want to make sure you take away is this idea of triage, okay? So how are we going to triage our patients in the ER? So we want to be able to identify those patients that need the rapid care and getting them to a provider quickly. So sometimes we can classify them into three categories where you have emergent, urgent, and non-urgent. Okay, so emergent, they're life-threatening, they need to see one immediately. Urgent, all right, so they need quick treatment, maybe within an hour or so, but it's not life-threatening. And then non-urgent, we can wait several hours before they sought care. So being able to identify, right, emergent is that patient that's having acute, chest pain, having jaw pain, having acute signs that they're having an MI would be an example. Urgent is maybe someone who's having abdominal pain, okay, just maybe abdominal pain with vomiting or things like that. And then non-urgent would be, someone who maybe even something like maybe they fell and hurt their hand or something like that. Or I'm going to show you. So another way that we can do this is emergency severity index. So this is a 1 through 5 triage scale. This is the scale that I use and a lot of emergency departments use. So 1 is the highest and 5 is the lowest. You can also see this as the number of interventions that a patient may need. So typically a 5 would be a patient who doesn't need any interventions. They may just need a prescription or things like that. So that would be your medication refill type patient. Those types of things. 4 would be something, it's non-life threatening. There's time, but they may need an intervention, even like an x-ray. These are typically like, someone broke their arm or things like that, like a closed fracture or, general limb pain and things. 3 is they likely will need at least 2 resources. So maybe they need a radiological scan as well as they need an IV or things like that. Big one I think here is abdominal pain, depending on even sometimes respiratory issues if it's more of like a stable respiratory issue. And then 2 is they really need to be seen, right? They're going to need significant resources, even may need to be seen within 10 minutes, okay? 3 said within 30 minutes. But this is the patient, again, acute chest pain, acute shortness of breath, those types of things. And then 1, this is a patient that needs to be seen immediately. They're unresponsive or they're, close to having a near unresponsive or whatever it might be. But this is another triage scale, the 1 through 5. This is one that's commonly being used. So I want you to be aware of that, and I want you to think of how you can, when you talk about like emergent, urgent versus non-urgent, and even the 1 through 5 scale, okay? Again, I haven't written your test yet, but at least even applying this to a case scenario. We talked about this and we talked about prioritization at our first class together for this exam. Okay. And then we talked about this as we just talked about homelessness, but deciding what the discharge plan would be, the disposition. Okay, case management. Case management, depending on where you work, sometimes it's heavily involved and sometimes isn't. I know I'm fast forwarding, but you guys can read this. The only other piece that I wanted to talk about here is this idea of trauma centers. Okay, Because you guys have probably heard the idea of a level 1 trauma center, okay, versus a level 2, level 3, whatever it might be. So a level 1 trauma center is the highest level. That's going to be able to accept all traumas. Hartford Hospital, St. Francis Hospital, those are level 1 trauma centers, Yale. They have all the resources that they need. They are typically at large teaching hospitals, okay. They have everything they need. They have all their resources. A level 2 this is more, Middlesex was a level 2, so it's a community hospital. We can provide vast care to most patients, but when we have more significant trauma specifically, like gunshots or stabbings or things like that, they might need to be transferred to a level 1 trauma center, okay? I don't know if you guys remember, but it was a bit back ago, but there was a patient who was a student at Wesleyan University, and there was someone who stalked her and shot her, and she was brought to Middlesex. But unfortunately, we were able to provide all the care that we could, but she died before even we were able to transfer her or things like that. Level 3 is going to be, again, this smaller, so they're going to be able to focus and provide some stabilization, but really, depending on the injury, are likely going to have to transfer. And then you can see level 4, these are going to be more those remote, those critical access hospitals, SMA, that we talked about. So having the idea of what a different level of a trauma center may be, again, that level 1 is the best. That's where if you have a significant trauma that you need to go. Charlotte's would be level 2. And Waterbury's probably, I'd have to double check it.
It's a level 2.
It's a level 2?
Yeah. Because we don't have
2 or 3. 3? I have to double check.
Charlotte's a 3. Yeah.
They say the difference is neuro. Is what we don't have. We don't have like neurosurgeons. We don't have that Waterbury. Whereas Yale and Hartford, like, yeah.
They don't have that resource.
Probably.
I didn't think they did.
Okay, the only other thing I wanted you guys to take away from this is this idea of primary survey. Okay, so in a primary survey, that's our ABCDE in emergency medicine. So the one difference is the A also includes cervical spine stabilization. Okay, so it's airway and cervical spine stabilization, and then the rest goes. Disability refers to neurological, so what's their neurological status, and exposure means taking all their clothes off and looking what's underneath. Okay, what are you missing? Okay, I'm going to let that be. There's some practice questions that I will let you guys can do even independently. The answers are there for you with the rationales. But why don't you go ahead and take your break, and then we can have a full hour left to do sepsis. Okay? It's 3:30. Why don't you guys, is 20 minutes enough?
Yep.
I'll try to start by like 3:55 so we can get that moving. Okay?
Yep.
I don't know if we still have it, but we have to have it.
I'm going to pee, then I'm hitting the machine.